This week on Inside Olympia, Washington's behavioral health system is under strain and under stress. What will it take to build and staff a system that serves some of Washington's most vulnerable citizens? On the program, Democratic State Representative Tina Orwall and Republican State Representative Greg Cheney.
From the TVW studio, it's Inside Olympia with host Austin Jenkins.
And welcome to Inside Olympia. Washington State has been trying for years to transform its behavioral health system to make it work better for those most in need while serving people in their communities instead of in state hospitals, at least when possible. But even as the system is being rebuilt, it is under tremendous strain and faces tremendous pressure. The combination of people experiencing acute mental illness and the impacts of the opioid crisis have stressed the system. So has the number of people in jails who need competency restoration services. There are also workforce issues that make it a challenge to serve all of those in need. Behavioral health is our topic this hour. Joining me now is Democratic State Representative Tina Orwall, who serves on the House Healthcare and Wellness Committee and has a professional background in public mental health. Also joining me is Republican Greg Cheney, who serves on the Civil Rights and Judiciary Committee and is a former National Alliance of Mental Illness board member in Southwest Washington. Welcome both of you to Inside Olympia. Good to see you.
Thank you.
Glad to have this conversation. I do want to start out just by, in terms of setting the table, hearing a little bit more about each of your backgrounds and interest in what brought you to this particular topic. And let me start with you, Representative Orwall. Tell us a little bit about your background outside of the legislature and why this is an issue that is so important to you.
Well, you know, I think mental health has touched many of us. It certainly has affected me personally, my family, my friends, my neighbors. I think my first exposure was growing up when my father never talked about his dad. And it wasn't until I got older I realized he had taken his life by suicide. And so sadly, I think there's often a lot of shame. There's a lot of people don't talk about it. And so to me, that's probably what drew me to the field. My background is I'm a social worker. I worked 20 years in behavioral health. I was a liaison at the state hospital. I helped people transition out of corrections. And then I also worked at a policy level in King and Pierce County, helping people, again, leave institutions and return to the community.
And of course, trying to get people out of institutions and back in the community is the organizing principle of what's going on in Washington right now, to the extent possible, and we'll be talking a lot more about that. You're new to the legislature.
I am.
Represent Southwest Washington, former NAMI board member. What's your interest?
Sure, I think it's very much similar. All of our families have been affected by mental health issues. I know mine certainly has. I think that is a trend, unfortunately, that's growing. It cuts across all demographic spaces, all incomes. It doesn't matter what your political values are. All of our families have mental health issues. We can all think of a close friend or family member who's struggling in these areas. So that's what got me involved. And you know, trying to reach out and figure out how do we help folks in crisis. And so as my day job, I'm an attorney down in Southwest Washington. So my law firm and I have handled LRA type issues. That is when someone has to go to the hospital because they're not safe to be left alone. I do indigent criminal defense, so oftentimes working with the poorest. Again, most of those cases that we get now either have a drug addiction and or mental health overlay on them. So really trying to figure out how do we solve these problems long term so that we can take these folks who are having challenges out of the criminal health system and put them into more a behavioral health system is why I'm so passionate about this goal and these concepts in this general area.
I think it's important probably for, again, the sake of this conversation and setting the table to just define what we're talking about when we talk about behavioral health. And, you know, terms that we have traditionally used are mental health. We also have talked about substance use, abuse, and treatment. But how is the legislature and the state thinking about and defining behavioral health? What does that encompass?
Well, you know, I think that's changed over the years, and I think we've gotten more comfortable and dedicated more of our time to work on behavioral health. And for me, you know, that is individuals struggling with mental health, substance use, but it's also a more holistic view that these are individuals with a lot of different needs, which also could include medical. And so I think as we've move forward with policies, we're trying to come at it in a way that I think is trying to see what does that individual need and how can the system respond.
It also seems like we're at such a critical point because of the confluence of all of the challenges that are facing Washington and other states. We've got an opioid crisis. Fentanyl is killing people in record numbers. Homelessness crisis. As you've indicated, an increase in people experiencing mental health issues. COVID, right, and all of the implications of that. So you just sort of pile on, layer on these things as if it wasn't complicated enough. You're really in the midst of a crisis, and I keep thinking of this sort of lame analogy of like trying to rebuild or build the airplane while you're flying it. Mm-hmm. But I'd like to hear you each speak a little bit to this moment in time we find ourselves in when we're addressing behavioral health.
Yeah, I think we're seeing, at least what I'm seeing with the folks that I'm working with, is the tremendous rise of attempted self-medication. It appears to be that maybe they can't get access, or at least they don't believe they can get access to the healthcare system. So I'm struggling, with my demons or challenges or whatever it might be. So I'm going to go out and self-medicate. And I met those folks who, and I'm sure Representative Orwall has, where they go from, you can see them over the course of 6 to 9 to 12 months, go from being a decent person with challenges to these narcotics are just changing their mind. It's like burning a mind almost. And I think that as we struggle, particularly now with the fentanyl challenges, we're seeing this growing population of a spiral, if you will, where they're struggling, so they self-medicate, and then the struggle becomes worse, they self-medicate more. And that's what I'm seeing in my practice. I don't know how to describe it other than it's just so sad, because you can see a mind burning in real time.
I would imagine there are times when you can't even have a conversation.
Correct.
Yeah. What's your observation about, especially because you've spent a career in this, like how bad is it compared to what you've seen before?
It's definitely increased, and I think of, just the emotional pain and the physical pain people are in. You think about COVID when people were isolated, and I think that escalated people's depression, their anxiety, and I think going to that whole thing of trauma history, right? I think COVID was traumatizing, and I don't think we've talked about it. I think it was especially hard on our youth, and we saw a report last month on suicide rates in our nation. They've gone up. And they've especially gone up for American Indian, Alaska Native, but also for youth populations, Black youth, youth of color. We are seeing the effects of social media that we haven't talked about, and the bullying and things that are happening again to our young adults. And so I think we're seeing these issues escalate. And I think I think we have an opportunity to create a system that can be more healing and responsive than the one we've had, which I think historically has often traumatized people who are in need of help. Because this is a sprawling topic and it's complicated and there's lots of sort of buckets, if you will, and I'm really glad you brought up youth and children, as well as the disproportionate impacts on Native Americans, people of color. How do you sort this out in your own mind, or start to break this into chunks that are understandable? Like how do you visualize a system that is perhaps broken, that is being rebuilt, that's not serving people well, but maybe down the road could? Right, I do think, and I appreciate the big picture conversation. And so, I've worked with Senator Dingler on 988. And again, that started nationally about a year ago. And it really has 3 components, which is a place to call, someone to respond, and a place to go. And so sometimes you just have to look at that big picture and start fixing each component. And
let me just repeat that, because I think it's important. So a place to call, someone to respond, and somewhere to go.
Yes.
And this is not a system we've really had in place.
And what's nice is there's a whole national vision of Crisis Now, and NAMI and other organizations have been really important to this movement. And so we can look at each part of the system and say, how's it working or not? So we have 3 988 call centers in our state. And we were able to see, we had never fully staffed them. They were understaffed. A lot of them had volunteers. And so we were able to pass legislation that actually had a fee. It's the same fee as 911.
That you pay on your phone bill.
That you pay on your phone bill. It tripled the staffing in our call centers. And so when 988 launched, instead of being behind, like we had a 50% call response, we have a 95. And so we were able to build the workforce for those calls. We also, because we had really good partnerships with the tribes, especially Volunteers of America, we were able to start a 988 tribal line, which is called Native and Strong, and the first in the nation. And so, again, I think every investment and opportunity, we should be looking at that lens of how do we build something better. And so this session, we're really looking at someone to respond and a place to go, and that's been a lot of our focus around the 988.
Because there's a place to call, but not necessarily someone to respond, not necessarily a place to go. Okay, so that's one key area of focus, is building out the 988 system, and really that represents also a shift away from kind of a law enforcement response, taking people to having police respond, perhaps taking someone to jail if there's nowhere else to go. What's another example of sort of a bucket or a way of chunking this out?
Well, I think you brought up workforce. We have huge shortages in the workforce, and recently Senator Dinkler and I took a group to Arizona, and one of the things we learned, because they have a very robust system, is that one of the organizations, 60% of the people employed have lived experience. And so again, our state has been kind of behind really valuing and hiring and training people with lived experience, which again could help some of our work shortages and provide better services.
So the idea being that perhaps one of the ways you address the workforce shortage is by hiring people who have personally experienced mental illness, maybe even been in the system, are stable once again, and maybe they're the obvious candidates to work in this field.
Mm-hmm. Absolutely.
Since you're working kind of at the intersection of behavioral health and it sounds like criminal justice in some cases, as well as the civil side, like when you're thinking about problem solving and solutions here, or pressure points,
right,
and you're coming in now, you're a practitioner in your outside job and then a policymaker here, like what do you want to target?
Yeah, I think part of what we need to target is we have for too long relied on our police to deal with these issues, and I think that's a mistake. Certainly most of the police officers I know are very compassionate, but this isn't their training. This isn't what we've asked them to do, and it's probably not quite what they've signed up for. And so I think that's a real challenge, is not relying on our police officers to be the first responders to mental health calls and crises. The other thing that we've done, I think historically, which is a mistake, is we've treated it as more of a criminal act. And yes, there's certainly an element when you're responding to someone in a mental health crisis of a community safety aspect. But all too often, I think historically, we've seen just that person taken to the jail. And the jails have become our de facto dumping grounds, for lack of a better term, for those dealing with mental illness and mental health crisis. And I don't think that's fair. I don't think that's just. I think there's better ways that we can help these folks. We can still help them in a secure facility, but not necessarily in a jail. And I've seen often that when you bring someone into a jail, the jail is the least conducive place for getting someone stabilized. I think the other challenge is on the emergency room side. You'll often have a 911 call, police show up. I've seen, I can't count the number of times, a mother will call, say, for an adult son, maybe 20s and 30s, a 911 call saying, hey, my son's out of control, can you please come help? There may be a slap or something. Police respond and immediately make an arrest because it's a domestic violence charge. If the person's still out of control, then they simply either dump them at the jail or dump them at the ER. They're not, the police, I want to be clear, the police aren't doing anything wrong. It's that we haven't given the policy tools to have different inputs into the mental health system. The only two ways to really get in right now are either through the criminal justice system or very narrowly through the emergency room. And I think that's part of what we're talking about here, is opening up other ways to get access to mental health resources and treatment other than simply through a jail or through an emergency room.
Yeah, and I'm glad you reminded, I didn't mention emergency rooms, but that's really key. And then, of course, that puts pressure on the emergency rooms that are trying to treat people who are in for other reasons. And so you've got delays, overflows, those issues. The mention of jails is a nice segue to also talk about kind of another big thing that the state is grappling with, which is the Trueblood decision, which requires the state to more quickly get people who are in jail evaluated. If they're not competent to stand trial, evaluated to see if they are competent or not, and if not, to get them restoration services, which need to happen in the state hospitals. And that's a court decision that puts pressure on the system, but it also acknowledges the fact that people are languishing in jail. So, Representative Orwall, how is the Trueblood decision overlaying this or informing the conversations that are happening at a policy level?
Well, it definitely has shaped a lot of our policy and our investments over the last couple of years. And, you know, I can even look close to my district where there's a crisis stabilization unit opening, and that's Trueblood dollars, right? Again, that's the alternatives we're talking about to jail. We're looking at our state hospital to create, you know, more beds there as well that would be able to do the competency evaluation. As someone who worked at Western, that makes me sad because, again, I think it should be the last resort. But again, we don't want people staying in our local jails either, you know, for long periods of time. We also have University of Washington that will be opening a number of psychiatric beds, and I think they're an important part of this equation. So I think with Trueblood, we are trying to invest our dollars in a different way, which actually overlaps greatly with 988 and the receiving centers we're creating. Again, we want this no wrong door where people can go and quickly be assessed and linked to behavioral health services. And so in the meantime, as we're building a better system, we do have to help the people that are in jails. And again, you know, I've been in most of the local jails and prisons, and often when someone has mental health, they're put in isolation, which again has them further deteriorate, and they don't necessarily get the care they need. The other thing that's really important is the medical assistant treatment, which, you know, the MAT for someone who's withdrawing. And so some of our jails, I have one in my area that can provide the medications needed, but a lot of the jails do not. And so people go in, you know, they're coming off these drugs, and then when they leave, if they use again, that's where we're seeing the really high rate of deaths around fentanyl. And so I think the Trueblood has put a spotlight on all the problems in our system. Those resources are starting to be reinvested in different areas, again, around crisis stabilization and other pieces, but it's taking time to build this new system, just like it's going to take time to build 988.
Well, in building this new system, it's been 5 years since the governor announced a shift toward treating people who are in state hospitals on a civil commitment as opposed to a forensic commitment. So they came not through the criminal justice system, but because they were found to be an imminent harm to themselves or others. So the idea was to shift those civil patients out into community-based facilities and really make Western State Hospital, to use the governor's term, a forensic center of excellence. The Seattle Times just did a big, in-depth report on this 5-year anniversary. The headline is How Washington's Plan to Transform Its Mental Health System Has Faltered, and essentially found that after 5 years, we're not there yet. So you've been here longer. I'll ask you the question. How do you respond to, why are we not, 5 years later, after this pronouncement and announcement, and civil wards are being closed, and people are being, looks like we've only built as many beds, and maybe not even as many as we've closed at Western State, or, you know, I think 2 of the 5 or 6 16-bed in community facilities only 2 of them have opened so far. So what's going on?
Well, I would say, and I can probably speak to King County, but at the same time that we're trying to fix it, we've had all these residential beds close. You know, group homes is often called, right? So we're like losing our capacity at the same time we're trying to expand it. And in King County, you know, we haven't done a good job creating enough housing with services for people who have behavioral health issues, right? And we have a homelessness crisis, and you can go in about any community and see people that are homeless that have mental health and substance use issues. So I think that the storm has been, the need has gotten greater. We've lost a lot of our group home and other kind of 24-hour facilities where people used to go. we're not creating that permanent supported housing with services at a rate to keep up with the number of needs. And so I do feel like things at the time we're trying to stabilize, the need is going up and the resources are going down. And I think, you know, and I think this is mentioned, we still have the funnel that puts people with mental health into jails and into EDs and not into the place they need to be. And I think until we really fix that, we're going to see this problem continue to escalate.
Okay, so I want to get back in a moment to how we're going to create that system and hear more about your trip to Arizona. But as you think about this, especially representing Southwest Washington and seeing the lack of inpatient beds available, and you know, this idea, I think most people would agree with it, that it would be better to treat somebody in their own community rather than sending them up to to Western State or over to Eastern State. But what are the particular challenges on the ground that you have seen in your region of the state?
Well, I mean, I think the biggest one is the workforce challenge. You know, we can build new facilities. That doesn't mean we can have staff there. Part of the challenge is when you open a new facility, a residential inpatient facility, for example, or a forensic restoration facility in the local community, we don't have the staff. That takes a very high level of credentialing. You know, registered nurses or whatever that level, social work, highly skilled individuals, as it should be. But the challenge then is, how do we get folks to move into Washington State from other areas, because we don't have a large enough pipeline at our universities, either University of Washington or WSU, to actually train the number of folks that we have. So we have to rely on moving into Washington to get those additional jobs filled. And that's a real challenge in my community, is finding folks who can do those jobs with the right credentialing to come in and willing to work at those facilities. I think that's part of when we talk about these no wrong door type of centers, folks with maybe a good head on their shoulders, so to speak, but perhaps with not quite the level of academic credentials. It allows us to fill those positions quicker, to essentially use those folks as triage, intake triage specialists, and then figure out where to go from there into maybe a more highly skilled care area. And I think that's a key component to freeing up those workforce shortages.
Yeah, because what I hear you saying also is, if you wait until somebody is acutely sick and needs to be inpatient, you can't just hire people with lower skills or fewer credentials to do that care. But on the front end, and this may get to the Arizona model, if you can get people maybe while they're in crisis, but sort of the tip of the crisis, not deep into it, you can steer them towards some help to avoid that. So let's hear a little bit more about what you saw in Arizona and what you might be able to bring back to Washington in terms of the, and I think you said in Phoenix, right? The police officers can pick somebody up, rather than taking them to jail or the ER, they can go to these other facilities and within 6 minutes, drop them off, get back in the street, and what happens? So tell us a little bit about the system.
Yeah, so we took a team down to Arizona, and it was really interesting. They have these, they call them 23-hour centers. We think there's some confusion. I think we're going to call them crisis relief centers. And
Are they closed for 1 hour a day?
They aren't, and that's a confusion. They're not, right?
Lunch hour.
But you know, if you provide care less than 24 hours, you're not a residential treatment facility, and that puts it more in the assessment, right? So that's the 23-hour. And so these centers are on a campus where maybe there's other beds around them, but they bring folks in. They have almost like a lobby area where there's like usually an RN, right, that greets like the first responder. It might be police, it could be EMS, it could be a mental health professional. So the person goes in and they're assessed. And what they have found is often we have the system where everyone has to get a medical clearance at emergency department, but they find that less than 1% actually have medical that warrant that. And so they do not route people through emergency departments that are having a behavioral health crisis. They have the ability to send them there and bring them back if needed. And so that's the front door. The officers basically, they gather just a limited amount of information, and then the officer leaves. And so again, they don't have to take a lot of their time and resources. They have a psychiatrist on site. They're assessing for medications. They have peers. A peer greets you at the door, which I think is a really important part to help people feel more connected and at ease, to know they're in a safe place. They, again, do a lot of triage and stabilization. They can take someone who's pretty acute. And they're also very effective of getting people to that next step if it does require inpatient, if it's connecting to outpatient. They really can set all those services up because people get lost during, crisis, right? You almost need someone to be tracking where they go and that they get that care. The models we're looking at for King County would also possibly co-locate a designated crisis responder. So for that person who does need to go inpatient, they would have that ability to have that assessment. So again, I think these places really are welcoming. They have people with lived experience to greet people and help stabilize them. It can have all different skill sets. One of the things that struck me several years ago, and I have to say, I was in a room of 45 social workers. These are master level. And I said, how many of you feel like you have the skills to work with someone in crisis who are suicidal? How many hands do you think went up? 2. So as we talk about the workforce, it's also getting the right skill set that people are comfortable working with people in crisis. And again, I think there's strategies we're looking at this session, but again, I think it's not just the workforce, but having the skills you need to work with someone in crisis.
We need to go to break in just a minute, but I want to ask you, we haven't sort of talked about the political fault lines or partisan fault lines. Typically, behavioral health brings Democrats and Republicans together, but is this an approach that you and your caucus embrace, this idea of standing up new facilities, creating kind of a third option besides the jail? And
I think generally so.
It's not going to be cheap.
It's not going to be cheap. I think there are some concerns over the cost. I think there's concerns over what decisions, could we have done it for cheaper if decisions had made 4 to 5 to 6 years ago, prior to Western State getting into such a terrible position that it is now with its federal certification. And I think there is some...
So there's some heartburn.
Some heartburn.
Yeah.
But I think that generally caucus recognizes we've got to do something because the current, what we're doing currently just isn't working. And we have made significant, I think, bipartisan investments in behavioral mental health space in the capital budget, for example. I think there's some of the operating budget, I'm more familiar with the capital budget side of it, in standing up new facilities. And in part because what we're hearing from our counties, at least I think I can speak for any number of counties with their jails, is they don't like the idea either that their jail and their local facilities dollars are really dealing with a whole bunch of people in there that are mental health patients more than they are
psychiatric hospital
because
without being a hospital.
Exactly, and what that means is then, yes, some of these folks are dangerous, they have to be held, but oftentimes, certainly during COVID, when you saw a drastic reduction in the number of jail beds available, people are getting released into the communities who are not mentally ill, who need to be held in jail, but they couldn't because those jail beds were being used more for mental health patients than they were for more of a clear-thinking criminal. I'm not sure that that's the right term, but a criminal who's not struggling with a mental health challenge.
Okay, let's take a break. When we come back, we're going to find out how Washington might stand up a system that looks like this, perhaps modeled on what they're doing in Arizona. Back in just a moment to continue our conversation on the state of behavioral health care in Washington.
The future of space exploration.
I think there's a lot of opportunity that we don't even know exists.
It really is an honor for the Sun Dome to be the host of the largest piece of public art.
Circle of light makes the building come alive. It really makes the building sing.
And welcome back to Inside Olympia. Our topic this hour is Washington's behavioral health system. Joining me once again is Democratic State Representative Tina Orwall and Republican State Representative Greg Cheney. And I want to just find out, so what will it take to create a system where there is a third door besides the jails, besides the ERs, that people in crisis can go through? I mean, might be sitting here saying, how come Arizona's got it and we don't? We're Washington State. Aren't we supposed to be leading on these things?
Well, what I would say is eventually we will be, because I think we were able to go and really see the the components we thought would work well in our state, and there's areas to improve. One of the things that we saw in Arizona is that 80% of the people that go to those centers are brought in the back of a police car, which we know is, again, traumatizing. And so one of the things we're trying to do is set up this rapid response team. This will be a clinical team that can respond to the 988 calls, and we anticipate about 5%.
Yeah, that's I think this is an important data point. So of the calls that go to 988, it's really very few, about 5%, that actually require a team to go out a response.
That is correct. And what's different about 988 than 911, and again, 988 you can call, text, or chat, is that it's a clinical intervention. 911 is a dispatch. I mean, they're trying to get someone out and respond like within 120 seconds to triage what they need. And so after the intervention, and our state also has next day appointments and other resources to connect with, about 5% do need a clinical intervention. And so we're trying to set up a system that whenever possible, that would be a clinical team. And what we're looking at is like our behavioral health agencies, and it may be EMS and fire, especially in more rural parts of the state, because that might allow for a more rapid response. And again, these teams would be dispatched by the 988 call center, and which is a little different. We don't have dispatch currently. And so we need to create these, and part of what we need to do is train. So part of the bill is to train our 911, our 988, our first responders, our behavioral health system, how to work together. Like, they need to know each other. We were in a room a couple years ago with 988 and 911, and they'd never met or spoken. Right, they need to have the ability to move calls back and forth. I sat in a 911. They get a lot of behavioral health calls. We need those routed to 988, right, so that they don't end up having that law enforcement response. And
well, I was struck, just spending a little bit of an aside here, but I spent some time with designated crisis responders, and I've also done a lot of ride-alongs over my years as a reporter with law enforcement, and it was just really interesting to sort of see the have-not world, because those crisis responders are in a cramped office. They're using cell phones. They're, I think, using their own cars. You know, they don't get into a car with a mobile data terminal. They don't have a dispatcher helping them. And, you know, they don't have the same tools that we give to EMS, that we give to law enforcement. They sort of seem like a lesser entity in this. And then they also have to call the police if they need, you know, assistance, and sort of, are you available? Can you meet me? You know, it's like different worlds.
Yes.
But that's my little observation aside. I want to be really specific here, though. So you see the 988 system as an opportunity to redo how we do crisis response in the state. These no wrong door facilities could be the future. How much is this going to cost? How long is it going to take to bring online? How do we do it in 39 counties? You know, not just King County.
Well, the capital budget is a key piece of that, and I think you'll see new investments this session. Some places are going to need more time to build and create that. We went all over the state during the interim, and a lot of the smaller areas, we were in Moses Lake, you know, they said, you know, please, we don't want a lot of red tape, you know, if it's a residential treatment facility, more than 23 hours, there's a lot of red tape to create these facilities. So I think the bill you're seeing this year is to try to get rid of some of that red tape so that they can be created. In my area, we're looking at funding two different ones, one in Federal Way and one through CMAR for youth. And if funded, they can be up and running within 12 months. But again, it's whether they have the capacity in other treatment locations to add a receiving center, or are they actually building one from the ground up.
Well, what's the reality check in terms of the number of years and because everybody is so desperate, right? Like, realistically, to build, you know, we can at this table talk about design and create a system. Sounds great, right? Like, it's a third way, it's a third door, it's an alternative. But what is the reality check on how much this will cost or how long it'll take, do you think? Are we 5, 10, 15 years out from?
I think we're 3 to 5 years. I think we'll start seeing more of them within the next 2 years. We already have one county, Pierce County, that has 2 of the receiving centers, but sadly they're underused because the whole system hasn't been educated that they're there, that people don't need to go through emergency departments. So it's not only creating them and investing in them, it's actually having the system understand how to tap into them. But it's going to take time, but I think there is dedication.
I think this issue, though, about the rural communities is really a challenge that looks very different on the west side of the state versus the east side of the state. One of the counties that I work in, the nearest DR is an hour and 15-minute away. There's no DC, well, there is DCR in the county, but if they're designated crisis responder, if they're off duty or someone else, they got to bring in someone from Clark County to fill in. It's a real challenge in Eastern Washington and Central Washington. I think we have to give some flexibility to the local community health departments to utilize these dollars, because I think they'd like to do these type of programs, but we have to recognize the geographic distances, and that just means time. How we locate these facilities, how we fund these facilities needs to look different for Central and Eastern Washington because of the geographic expanse. And I think it also has to look a little bit differently because you have very small police departments that even at a police department may only have 1 to 2 officers on duty at a nighttime, right? And they might be an hour away dealing with a DUI driver instead of these calls. So I think it has to look a little bit different. I want to go back to something you said, though, a few minutes ago. Oregon has had a really interesting program for the last year or two down in the Eugene area called Cahoots. Mm-hmm. And what they're doing is trying to send out with police calls also another social worker or someone akin to that who can go out on these calls so that when the officers arrive at the scene, because there is a safety component to the mental health crisis, there is also someone there who's a trained worker who can start stabilizing that person right at the scene, helping them. And I think they have seen some success down in Oregon with that program, and I think it holds some real novel, good approach to when there is a safety risk or a security risk to co-deploying these resources to the scene, perhaps combining 988 and 911 resources, but coordinating them so as to get a more optimal outcome.
And how I would build on that is, again, the teaming up of EMS and fire may be actually even a better approach in the sense they can do the medical, right? They're non-law enforcement, but they're very comfortable going into a scene and trying to figure out, how do you secure it?
They might be in a better position to determine if the person needs to go to a hospital or not.
Yes.
Yeah. Mm-hmm. So I'm hearing you say some flexibility. Communities need to be able to design this in a way that works for them. Again, trying to shift more and more away from law enforcement, more synergy. And I will just sort of observe, because I think it also helps to sort of put this in context, is that, and this is a little bit reductionist, but 5 years ago when the governor was talking about transforming the state's behavioral health system, it was really about, we're going to move civil patients into the community, and then we were talking about 16-bed facilities. What I think sounds new and different to me now is this idea of the third door. Or a fourth, maybe it's a fourth, but it's not just inpatient facilities. It's trying to create a new place for people to go in crisis. So that seems new, different, perhaps significant. I do want to ask you about, and sort of click through in the time we have left, some of the ongoing systemic challenges. And I also want to talk to you about the Blake decision and how we treat substance use abuse. One is the children. Mental health. Seattle Times has also done a lot of reporting, and I have as well over the years, about kids being stuck in hospitals, stuck in ERs, sent to out-of-state facilities because of a lack of placements. You've noted, Representative Orwall, that kids are fueling in many ways the greater pressures on this system. What are we doing to address that? I mean, it's bad enough to have adults stuck in, there was lawsuits over this years ago, adults stuck in ERs, now kids stuck in ERs.
Yes. It's heartbreaking and traumatizing. I went out to Children's Hospital and got to see what was going on in their emergency department, and I know they're really wanting to be a partner in some of the new resources we're talking about. We held this planning group in South King County, and we invited a lot of youth, and we invited providers, and Janice, who was a student from Kent, said, we need help, and we need help now. And one of the approaches we're looking at, because it is going to take time, even for the youth receiving centers that we're working on, is we got to also get more behavioral health in the schools. And so, like, one of the programs we're looking at is, how do you have newly certified social workers who need hours to get trained in the approaches that actually are effective of working with youth in crisis who are suicidal and help them into the schools. And so we do have a pilot project that got funded, but we do have to get more services into the schools. We also have these investment of the youth teams, and I think the youth teams are very different than the adult teams because they go into the homes and try to stabilize within the home. So there has been new investments for these children and youth crisis teams. Again, we're looking at youth receiving centers as well, and the one we're looking at King County would be co-located with a youth detox and youth substance use treatment facility, and they would be doing all of it, and that's through CMAR. So I think we're looking at the models, but again, they need help now, and we need to figure out how to get more of that mental health into the schools that's actually a clinical intervention. And I think we're doing some good work, but we need to expand that as well.
Briefly, and then I want to...
Briefly,
yeah.
2 quick points. One, I think we've got to rethink how the state funds when we don't have beds. Someone's dropped off the ER. I'll give an example. I had a client who was dropped off in an ER for a severe developmental disability, nothing physically wrong, but someone didn't know what else to do with him and dropped him off the ER. The ER cannot discharge him by federal law until there's a safe place to live. That process took 9 months. There was
that's happened
a lot, and there was no money to reimburse the hospital for that use of that ER bed. So I think that has to be fixed in a matter of fundamental fairness to the hospitals.
And also to those individuals.
And those individuals,
yeah, I mean, being in a hospital is bad enough. Being in a hospital with no medical need to be there,
right? Yep.
It's a nightmare.
Yeah, we need to make a way to reimburse the hospitals for that cost. The other thing I'd add is that we have to educate in the schools about the danger of fentanyl. Our local Clark County Sheriff's Office has been doing a great job of that, but that has to be rolled out statewide. When you have severely hard narcotics that will kill you instantly, looking like candy, that is an education problem that we have to start telling right now. It's critically important that we tell that danger and education piece immediately.
Well, that gives us a transition to the Blake decision, which tossed out Washington's felony drug possession law. The legislature did a temporary fix, and now you're trying to come up with a permanent fix. Remains very controversial. The latest version of the bill passed out of the House moves drug possession to a misdemeanor as opposed to a gross misdemeanor as the Senate had it. But obviously the focus is going to be on trying to increase access to treatment. And there seems to be bipartisan support for that. But again, you run into all the same issues. What does that system look like? Where's the workforce going to look like? If you're not jailing people in the meantime, and you don't have the infrastructure to treat people, how do you get people to go into treatment if they won't go into? I mean, all of these is so, I mean, this is a whole other topic, right? But as you're thinking about this, and we don't need to dwell too much on the should it be a misdemeanor, gross misdemeanor, but I think everybody's skeptical that we're ready for some big transformation because it's going to take so long to build this new system, whatever that looks like.
And I think it was interesting because the Blake bill did get modified in the House. I think there was a focus on how do you have people in the community that are engaging, they talk about LEAD, that are actually out there working with people with substance use. How do you have a carrot and a stick, right? We want to try to get people into treatment, but if that's not, if they're not connecting to treatment, then how do you do more diversion programs where they are reporting back and you do have that ability to actually maybe put them in more treatment that could include some involuntary treatment. So I think we were trying to balance out both.
Is that in this latest bill?
Yeah. Well,
some stick?
There is some stick with some diversion. Like you are, trying to get folks to go into treatment, doing that engagement work, but I think there's that recognition for people that aren't making those connections that are coming back with law enforcement that at some point there does need to be a diversion. You may have looked at that more carefully. Well, and it's interesting because I
know that like with drug courts, there's some, one of the things that makes, I think Danny Westing in the Seattle Times talked about this, that if you go to drug court, I think generally if you have felony charges pending and that can be more compelling to somebody if they know that the default if they're not participating in treatment is felony charges, misdemeanor, gross misdemeanor, I think that becomes a question too, is what is a appropriate and effective, and I don't like the term stick, but carrots.
Well, I think I like to use the word accountability. I mean, I think one of the things we see in the drug system, the drug courts, those are the specialty courts that are working in the mental health courts. You have wraparound services. I think this bill somewhat gets to that problem. It has to be fully resourced, but having the wraparound services, substance abuse, mental health, oftentimes are co-occurring and coexisting issues. But what I'm concerned about in the bill, I voted for it because I didn't want to see it become completely decriminalized later this year, but I am concerned that the accountability prong, and it's not necessarily about putting people in jail, although that may be a component to it if it's repetitive, not going to treatment or refusing to do treatment. But part of what is so important is the accountability prong, going up to the judge and saying, Judge, I've relapsed, or no, Judge, I've been clean and sober for this many days. You often hear a significant level of pride in, I've been sober for X number of days, Judge, and the judge saying, great job, keep on it, go with it. On the other hand, I think there does have to be that accountability, because I have those clients too who obviously have substance abuse issues, who are simply refusing to deal with them.
And I will just say, you're not the first person working in public defense who has said this, which I find interesting.
Yeah, and
you're not a prosecutor.
No, I'm not. But unfortunately, it's the reality of what we see. There is always going to be a segment of the population who is not wanting help and just refusing to accept help. And I do fear that the bill that was passed does not give sufficient options to the prosecutors and the judges to deal with that group of people who's just not interested in following along and getting the treatment.
So this is playing out in a very interesting way in Bellingham. I just mentioned Danny Weston, the columnist for the Seattle Times, wrote about the city council in Bellingham passing an ordinance or changing the rules there that now says if somebody is doing drugs in open, that's a arrestable offense now for the police. And this is a very liberal city in Washington. And what sort of the takeaway from the column is that they're at wit's end. They've got open air drug consumption. They don't have access to treatment. Nobody on that council thinks jail is the right answer, but they're not going to wait around for the state to create the system, and they got to do something now. I mean, that suggests that we are so late to this that we failed. And then the question is, what would you say as a state lawmaker on the front lines of this to say the Bellingham City Council about what they can expect, what's coming their way besides jail when it comes to drug treatment and getting people who they're picking up all the time routed into treatment, not into jail, and accountability. What does that system look like? We talked about the mental health, the third door for mental health. What is the drug treatment system model for the future going to look like?
And I think that's an interesting question. I always feel like there's tension in the substance use, because you have one that's abstinence, in that you go and you do these programs and you do your 12 steps, and then you have your medically assisted treatment, which is that some of these highly addictive drugs people are on, that there are other alternative medications that help them with that withdrawal, help them not have the drug-seeking behavior. And I think it's very hard to cite opioid treatment. Mm-hmm. Right. Yeah. Yet that's what a lot of communities need.
Like we're putting
having
a treatment facility in.
Right.
Yeah. Yeah.
And so I think that's part of the tension. Is I think these cities want the answers, but then when you go to cite the treatment, it's very difficult. And yet that is one of the really promising approaches. The number of medications that can be prescribed that can help that person that's coming off a highly, highly addictive substance, which has altered their brain chemistry, which does make it difficult to make good decisions. It's also it's very common for people to relapse and go into treatment multiple times. And we can't see that necessarily as a failure. That's often part of the journey, right? And so I think, again,
but you have to have treatment on demand when people want it.
Yes.
You have to have treatment, again, on demand when they need it. So it needs to be available, it needs to be accessible.
Right, and again, these 23-hour facilities, these crisis relief, could be one of the places where people go that do need that assessment and that linkage to treatment. So again, I think that is part of the answer, is getting these facilities up and running. The other thing that hasn't come up, and it comes up because often people are also suicidal that are abusing substances, is that, you have a system where we have a lot of inpatient psychiatric beds that say no, which is really odd to me, yet we're going to create these no wrong doors that are going to say yes. And once they're in the no wrong door, I think they're going to have a lot better access to these other resources than people do now. I think emergency departments get frustrated because the inpatient units won't take someone, or the substance treatment facilities. So again, I think it is a little bit of a shift around the system, putting pressure on the system to provide treatment.
Let me ask you the same question. How long do you think it's going to take to build a robust substance abuse treatment system in this state that can meet the need? I mean, at the stat, just King County alone, 374 overdose deaths to date this year, 79% increase over last year, and last year was a record. I mean, you mentioned it. Fentanyl is deadly.
Yeah.
We are in the throes of a huge crisis.
And I had the fentanyl testing strip bill and working
to legalize.
To legalize, because the testing strips aren't legal.
Right.
And I work with Genevieve, who lost her daughter, 27-year-old, beautiful daughter, because she thought she was taking OxyContin. And so when you say how long, I started during the Great Recession. We cut substance use. We cut behavioral health. We're just starting to reinvest, and I think reinvest in meaningful ways. So it is going to take time. We also decentralize our substance use. It used to be we could do these fast tracks, but now it's decentralized where agencies do their own screening. And so how do we make sure those with the most need are getting into treatment? And I think we might have to look at that front door through these new centers of how we rapidly get people into treatment. And we used to have that mechanism in our state.
I think we have to talk about one other component here, and that is the CMS, Centers for Medicaid, Medicare, at the federal level, who have the rule about the 16-bed limit, if you will. That is a tremendous roadblock in my view, and I've talked to our local congresswoman about that, because what happens is you have to cite all these facilities. Instead of the reason those rules came into place is to effectively take away these huge dormitories in the 1950s, which we can all agree were terrible, awful facilities. But what we've done by setting a 16-bed limit is you have to cite then 4 16-bed facilities in your county instead of having one 4-story facility. You save on construction costs. You can get efficiency from your workforce, because instead of separating your workforce out where they're having to drive around for these highly skilled social workers or nurses, by having one facility, we can do it humanely, but we need to raise that. That has to be done at the federal level.
Is there a waiver the state can apply for?
Well, there are, but again, there may be waivers that can be done, and I think they can be done in limited circumstances. But the point is, I think as a society, at least at the federal level, we have to talk about, do these rules make sense? And then you reduce the pressure on the citing issues that you're talking about, because every community, I guarantee you, the local county commission is going to come, why are you putting it in my backyard? Well, and one of the ways you can relieve some of that pressure is by increasing that 16-bed limit.
Yes, no, I think that's a really important topic. The other thing I'd say, and we're partnering with our cities and counties, they are so excited about these crisis receiving centers. I've never seen the cities ask for a resource. And so there is a different dynamic with this resource than we've seen with other treatment.
So just a couple minutes left. I want to ask you about Medicaid reimbursement rates. I know there's a significant 20% increase that's been proposed for services for youth, autistic youth. But one of the constant criticisms I hear is that our behavioral health system is really crippled by inadequate Medicaid reimbursement rates. And that's a 50-50 share with the feds, but what is or can the state legislature do around that? I mean, A, do you agree with that premise, and B, what's the solution?
Yeah, we are trying to increase some of our rates. I know it's in the House budget. I'm not sure about the Senate. And I think one of the criticisms I heard is, like, if we give a 7% increase, the providers don't always get the dollars, and there's been a disconnect, and we're really trying to say, how do we get those dollars to the providers?
Well, and private equity firms are snapping up a lot of these service providers, and so then the question becomes, where is the money going?
And we're also trying to look at the certified clinic model, which is a higher reimbursement of Medicaid. And our state applied to be a pilot, and we didn't get our application approved. But there is this new certified behavioral health clinics that actually have the higher Medicaid reimbursement, like our federally qualified health clinics, right? And so our state needs to continue to pursue that, because that would be a huge bump in the Medicaid reimbursement for all of our behavioral health centers that are part of that.
I want to mention that I know access to prescription drugs, NAMI has is very concerned about just access to psychiatric prescribers. I mean, that, again, this gets to workforce issues and who can prescribe. Just very briefly, does Washington's Involuntary Treatment Act need? I know we have outpatient treatment now, but does that need to be relooked at or reformed?
I don't know that it needs to be reformed. I think it needs to be resourced. So I work in that ITA space. My law firm handles those for Southwest Washington.
And sorry to be, but just very briefly because we are out of time. Go ahead.
Yeah, no, I think we do need to resource them. I'm not sure the reform is necessarily the right. You don't hear a lot of complaints about how the system is working. There may be some in King County, but I don't know that those are shared necessarily in the rest of the state. But there is a resourcing problem, certainly.
I think we often put people on the ITAs, but we don't revoke until they are fully decompensated. And there are mechanisms. If we acted more quickly before someone's fully decompensated, I think they could get better care.
Okay. Great. Well, we could keep going, but we're out of time, so we'll stop there. Representative Tina Orwall, Representative Greg Cheney, thank you so much for the robust and thoughtful conversation. Appreciate it very much. Thank you for watching Inside Olympia, and we will see you again next week.